So now I'm pleased to introduce the closing speaker for the 2017 Infoway Partnership Conference. The Sequoia project is the leading interoperability organization in the United States, pioneering the nation's first public-private health data sharing network and a new national-level trust framework for the exchange among networks. Mariann Yeager, CEO of the Sequoia project, is going to share valuable insights from building nationwide health data sharing initiatives which enable the exchange across disparate geographies, vendors, technologies, and networks. Her presentation will include a history of the evolving market and government dynamics, privacy challenges, incentives to sharing data, and other lessons learned regarding the barriers to the exchange faced in Canada and the US. So please join me in a warm welcome for Mariann.
All right. Well, good afternoon, and I want to extend a very special thank you to Lynn and Michael for inviting me to speak with you. I came here not only to really share our experiences with supporting a national level initiative, but to really learn from you. And I really wish I could have spent more time because I just feel that every conversation is just unveiling all these other perspectives I didn't really fully appreciate. So I thought I'd start by talking a little bit about the Sequoia project. So we are a nonprofit with a public mission. Our sole focus is advancing interoperability for the public good. We actually had a very unique beginning, which I'll talk a little bit about, where we actually took over and became a steward of an initiative that was started by the Department of Health and Human Services in the US, and we were actually formed to take that forward. But what we realized was there are probably other things we'd probably need to work on. Interoperability is very complicated. There's so many challenges. And it's probably a good thing that we had the foresight to structure the company as we did so that we could actually support multiple independently governed initiatives and also take on other projects. And so that was really the spirit with which we were formed. But I really want to focus and drill down a little bit further on the first initiative that we became involved in, and it was really the impetus to form the company, believe it or not, and that's the eHealth Exchange. So what is this eHealth Exchange? Well, it is actually a group of data sharing partners, which could be governmental agencies, health systems, pharmacies, payers, et cetera, who are all sharing information with each other securely over the internet without a single intermediary. And they do so because they are bound by complying with the common legal agreement, which actually points to a set of use cases that they'll support, a common set of corresponding implementation guides and standards and policies, and it's governed by the community. Because this activity predated Sequoia, they govern themselves. So that's a little bit about what it is, and I'll unpack that a little bit. What's very unique about our story is the beginning of this activity. So the Sequoia project was actually formed in 2012, but you can see we have a 10-year history in supporting this activity, and I actually was involved as a contractor to the HHS in the US to work on this project. And so at the time I thought, well, this is kind of interesting, we'll see where it goes. But back in 2007 or 2008, the federal government formed and sponsored an initiative to develop a nationwide network. And what they did, rather than prescribing what the network would do and how it was architected and structured and the policies, they actually brought together a group of 12 federal agencies and 18 private sector organizations under contract and grant and formed what we called a cooperative. And the cooperative had several goals. One is they had to facilitate agreement on a common legal agreement that they would all sign and that they would all use to actually share data in production. Now remember, this is an era where very much in its infancy of policymaking, consent issues huge, very low adoption of electronic health record systems, which I know in your world are EMRs and clinical information systems. We sort of lump all that together. And then also they had to agree to begin sharing data with each other for a common set of use cases. So it was very lofty goals, but the idea was they had to begin sharing data in 2009, real data, real PII. And it seemed incredibly impossible. And I remember thinking, there is no way this is going to happen. And there was a lot of passion and angst, but by having those hard deadlines and the firm commitment, and because it was that cooperative spirit, it wasn't the government prescribing or the industry or particular technology interests trying to, change the market. It was this cooperative, we have to make this work. And in February 28, 2009, the first records were actually shared between a regional health information exchange network in Virginia, which is my home state, and the Social Security Administration. And from there, incrementally, more health information networks and federal agencies began adding that capability to share information. And in 2011, there was a recognition that this is not a proof of concept, this is not a pilot. Real data was being transmitted for a couple hundred, maybe 20 hospitals, health systems across maybe 8 states, and with, a couple of federal agencies. And at the time, the federal government in the US had shifted their focus to high-tech agendas and meaningful use. And so I actually facilitated the business planning process with a group of private sector partners and federal agencies, which led to the formation of the Sequoia project. So we were basically assumed reins for this network in October of 2012 and have grown considerably. So this cooperative really provided a foundation that allowed information to flow while being able to adapt. And I'll share a little bit more about the lessons learned. I mean, I won't read the slide to you, but it really truly is national level footprint, all 50 states, 4 federal agencies. The eHealth exchange is the only way that the Department of Defense is able to share and access information with the private sector for the 9.4 million TRICARE beneficiaries. So those are active duty military retirees and their families. It's the principal way the Veterans Health Administration can share information and access information from the private sector. Again, 9 million veterans today, projected in the next few years, 20 million veterans, as well as the principal way that CMS is able to receive quality measures for their end-stage renal disease program. And this is a way that the Social Security Administration can access medical documentation to substantiate a claimant's claim for disability benefits. So instead of waiting months and months for paper in order for a disabled person to receive compensation, it's a couple weeks. So there are about 180 nodes. And the reason why I mention that is those come in the form of a few different flavors. One could be a regional or state health information exchange network. So there are about 47 of those nodes in the US, as well as large health systems like Kaiser Permanente, Cleveland Clinic, and those are also themselves represented. But collectively, it's really truly more than, it's probably closer to 70% of all US hospitals and tens of thousands of medical groups. Every CVS Minute Clinic, every Walgreens is now connected. So it sounds so great. I mean, every time I share that, I'm thinking, we solved it. No, not really. We have so many problems. That's a real story. So, and I'll share a little bit more about the challenges and the practicality of it, because we're really laying the pipes for this nationwide data sharing, but it doesn't mean the water quality is all that great. So. So when the network was first formed, there were a couple different approaches contemplated. One was, well, should the government or industry just support a single private or centralized network or public network? And the federal policy in the US is really more favorable to distributed network architectures. That was really the precedent set by telecom. So for a health information network, there was a strong preference for federation or distributed architecture. Now the fully federated approach would be something as open as the internet. Just leave it up to the masses to figure out, and there was no way that was going to fly. There were just too many patient safety and privacy considerations and the like. So that was really what led to the structuring of the eHealth exchange as a federated network, but with smart services. And I'll talk a little bit about that. And that's what we're really building upon. And I think as I start sharing a little bit more about the evolution, you might start making the connections that Lynn and I were making. Wow, you all are exploring some things that are really, really akin to what we're doing. So the idea, the goal here was to have one national network, and there are many national networks, by the way. The eHealth exchange is one. It turns out there are about 10 or 12 now, so we'll talk about that separately. But it's a pretty big one. But the idea was to have it be multi-purpose. So if you can come up with a common foundation of what's needed for trust, for a multitude of use cases, and what the minimal technical services were, that you could use that same trust framework, you could use the same technical foundation for many, many different purposes. And again, that all sounds great in theory, but guess what? It worked. And we're still evolving over time, but the ability to reuse that common legal agreement, to reuse that without having to establish a separate use e-prescribing network, a separate results routing network, a separate event notification network, a separate image exchange network, a separate. What if you had one network that could support a multitude of things, but you still had the ability to layer services on top? And that's really what this was about. To give you a flavor of the national use cases that are supported today, this is principally used for treatment and care coordination, and I mentioned the active military and their families, 100 million Americans, right? So it's a pretty substantial portion of our population, about 30%, and disability determination. But what's so fascinating, because now we're moving from fee-for-service to value-based care models where it's more contracting for care, is that the employers are stepping up as purchasers of care and starting to negotiate these value-based care models, which we saw with Intel Corporation. So Intel decided to use the eHealth Exchange network and required in their contracts that these different care organizations that they contracted with, in addition to customer satisfaction and quality and cost, they are measured and held accountable on interoperability. And so that was really the impetus for them, these healthcare provider organizations who had been waiting in the wings. There was no impetus for them to really start sharing records within a handful of weeks to just go live and start sharing tens of thousands of summary records, literally within a handful of weeks. So we think that that's a pretty big movement in the US. But it's also a way for veterans who receive immunizations in the private sector. That data is pushed to the VA, so immunization management. It's a being able to knit together the different networks that support event notifications. Are you all working much on that? Where I presented an ED and it sends an alert to my PCP and specialist so that they can proactively follow up. Where there's lots of that connectivity occurring locally. We want to tie that together because we receive care all over the place, and it's usually outside of a particular region. And then others, the one that's so fascinating, I mean, literally this just happened 2 weeks ago, is disaster response. We had all these horrible events, and there were these displaced people, and there was no way to access their health information. Well, guess what? The federal government incubated a national service that they piloted, and we're talking to them now saying, can we take that nationally and really build on this core infrastructure that we support? I think I'll just skip through this a little bit. This is just a workflow for how the query transactions occur for CCDs, but you can see it's basically, you know, point-to-point arrangements, and they'll be able to find exchange partners through a directory. So when I talked to Lynn about preparing for this, she said there are policy and privacy people here, so I wanted to spend a minute to talk about the legal agreement that really supports the eHealth Exchange network. So think 8 years ago, 2009, totally different world in health IT. I mean, it was just the issues that we worried about back then. Some of them are really not an issue anymore, but it was fairly groundbreaking because this was an agreement that had a common set of terms that every single participant in this network had to abide by, meaning there was one agreement and many signatures. It was like a treaty, literally. I mean, and I had the dubious honor of working with all the governmental agencies to try to convince them to sign this, which was really, I don't know, that was fun. But they did. They actually signed this thing, which, I mean, to this day is kind of amazing. But here's really kind of the key tenets of what's in this agreement. It was a way to establish the uniform minimum for data sharing. In other words, this is you agree to share information with others if you abide by these common set of responsibilities and obligations without expecting the other party to enter into other agreements with you or go through these separate negotiations of point-to-point, connections. There was also the assurance of security and privacy and establishing a minimum for that. That was important. There was also a recognition that there's going to be a lot of diversity and consent requirements and different policies locally, and that there should be a healthy respect for what we call local autonomy. So I imagine there are different policies between provinces, right? They maybe have different ways of doing things. Well, in our world, that's fine. Those decisions are local. They should be respected locally, but they just have to be applied consistently instead of discriminating and having one set of rules and expectations for one party and not another. And that there also, there's building on the existing legal arrangements and relationships that partners had with their employees and their vendors. And there was also a healthy respect for, boy, we didn't know what to expect in 2009, and there was a recognition there had to be a process to modify this agreement over time. And guess what we're doing? We're amending the DRSA 8 years later, which is frightening, but it's okay, we're all right. So here are the components of the agreement itself. It actually established the authority of a governing committee. So Sequoia Project has no authority over this group whatsoever. In fact, If they don't like us or if they don't think we're doing a good job, they can pick someone else. So that gives you a sense of how much autonomy. In fact, even though we provide staff support and we'll do the legwork and the analysis, they sometimes disagree with what we suggest. So, and that's because it's their network. We're there, we're a steward, we're advancing this for the public good. And anyway, so that's a huge aspect of getting buy-in and trust that the partners in the network run the network. So there's no real top-down. It also assures those very clear, transparent expectations across the board. So while the legal agreement was supposed to be enduring and not changing all the time, it was important to be able to point to supplemental information, implementation guides, operational policies, technical guidance requirements, use cases. So that was another important. Equitable data sharing. So if you're going to request data for treatment, well, you also have to be offering data for treatment purposes. It can't just be a one-way street. That was a huge issue back in '09. Not so much now because there's more of a culture of data sharing, but that was definitely it. I mentioned local autonomy. Future use is an issue that was just almost paralyzing about how far do you go to prescribe what someone can do with the data once they receive it. And the way the DERSA addressed it was, well, once the recipient receives the data and incorporates it into their system of record, applicable law applies. So there was no way to try to convey these future permissions and tagging to the data once it was in someone else's system of record. So that was a huge one that may or may not fly for you all, but that was pretty monumental. And then also having coordinated security incident response. Knock on wood, we've only had one false alarm. That's not wood, knock on wood. But it was kind of important for the partners to have an obligation to notify their partners immediately, notify the coordinating committee, notify us, that we would have mechanisms to inactivate their digital credentials, to cease data sharing, and that to cooperate in the resolution. And I have a feeling we'll be exercising this process at some point. If the NSA is compromised, I have a feeling something's not far behind. And then also to allow for flexibility. So it's very important not to build this network on a particular technology, to not have it hardwired to one thing, because we're seeing that technology and standards are evolving, and that this had to have that as well. It was also important that there be accountability. So one of the initial considerations was, well, should compliance with this be voluntary? And there was a uniform no. If you're a bad actor, if you're not complying, you have to have skin in the game, and you have to be held accountable. And really, what the committee has the ability to do is to suspend or revoke participants, and they can do so themselves. So it's very important to have a coordinated issue resolution process to avoid litigation. Americans love to sue each other, and that's another big liability issue. And we had to make sure that this is neutral, right? This cannot be, this is kind of like Switzerland, but it had to be really neutral, and to make sure everybody shared their own, they are responsible for their own liability. And that there will also flow down to those who use their systems and who provide the technology to support it. So I think I mentioned that it was very important to make sure that this could live, that this was a living, breathing document. But after living through a multi-agency clearance process, there was no way on earth I wanted to do that. Again, we knew that that was just not viable. When you think about it, we had to get authorization for the Undersecretary of Health at the Department of Defense to sign this agreement. We had to have the Secretary of Health at the Veterans Health Administration sign it. We had to have the Commissioner of the Social Security Administration sign it. That means all their attorneys had to agree. And that was really, really difficult. So it was very important to try to find the tenets of this that would not change, and to really have a process that, if heaven forbid we have to do it, which we're doing now, that we could adapt. And so there was a change process which we're undergoing right now. So what did we learn? Well, overall, some things that we pined over in 2009 were not a big deal at all. And I know you're going to find this just probably alarming. You're probably going to question me on it later, is consent wasn't that big a deal, because we didn't try to harmonize a national consent model. There's no way to get 50 states and territories to agree on that. Rather, we said it defers to local law. But you cannot require someone outside of your jurisdiction to get the consent on your behalf. And furthermore, we'll have a way to convey the permissions digitally so that you can automate the workflow to get the manual paper out of of the loop. And so with the Social Security Administration, that workflow works quite well. It's been automated. They do tens of millions of transactions a year, and that works well. And also privacy and security, again, we tend to really get hung up in trying to harmonize every different requirement. We just had to say there's no way to have one high bar for everybody, because that's what the federal agencies wanted. They want, Department of Defense level security, and the private sector said we can't do that. So we said, well, here's the baseline, and by the way, federal partners, you cannot require and impose your federal security requirements on the private sector. It's not conducive to data sharing. And then there are some things that are really still problematic. I understand you all might have this issue too with patient matching. Is that a problem for you all? So we've done work at a company level to kind of come up with common guidelines on the data attributes and rules for matching, because if there's consistency, there's higher degree of match rates. And what we're also doing is we want to kind of test the assumptions of why can't we use the Social Security number? Secondary identifiers result in a 99.9% accuracy rate, but we can't use it. So what's more important, perfection and privacy or patient safety? So that's kind of an interesting debate, that the common assumption that you cannot use a Social Security number, not everyone has one, they're duplicates. Well, you know what? If you have one, you're a lot more likely to have the right patient. So what's, sort of pros and cons. So part of our public good activities, I've spent a lot of time on Capitol Hill in Washington, D.C., which I never wanted to do. I never had an interest in doing. But we have to inform policymakers on the practical realities, and so that's some of what we've done. Value in the data and having consistency in the use of clinical benefit of the data. Again, I talked about we've laid the pipes, but the water quality is not so great. Yeah, this is a real problem. And again, and this is another lesson learned I'll touch on later, was we had to retrofit some of the interoperability requirements after EHR deployments. So it's easier to ask a vendor to build it in the first place than to not have it on the list and then try to have them change it later. So that's, but the one thing I will say that was really world-changing for us was that by having the federal government stimulate the adoption of electronic health records, again, our challenge in 2009 was most of information was on paper. So you built this network, and I'm thinking, well, mostly paper, what are we trying to do? But that really did work. And then also having a business case. So we've built it, right, thinking they will come, but there has to be a business impetus and value to the data to accelerate it. And that's where really value-based care models come into play. So there are some overarching things that we're doing starting last year and this year, and that is because we're dealing with a federated network, there tends to be a lot of variability across those 180 nodes. And so what can we do? Where are the areas where it makes sense, where it's prudent to have more active oversight? I would hesitate to say monitoring, but it's more post-production testing. So that's sort of what we're doing is, in addition to building the network, is really shifting the paradigm from I'm going to do product certification, or we're going to do profile testing pre-production. A lot of these systems, the test environment has no reflection on the production environment. So we found we were doing all this gating testing only to find that it didn't detect any of the issues in production because it was a completely different instance or different configurations. So we've come up with a way without having access to PII to actually do that, which is kind of cool. And then we also realized security testing is a big deal. So for this network, the security model is around X.509 PKI certificates, so we issue and manage those to authorized participants. And what we discovered after testing, we thought that this was going to be, we wanted to test to make sure it was properly configured, that it would reject expired or invalid certificates, and we discovered, horror of all horrors, nobody was doing it right. So we proactively, even though it's the participant's responsibility, test every node to make sure that they've properly installed and configured their PKI certificates. So those are just some of the things that we're doing. The other thing we're doing, it's not on this slide, but I was talking to Lynn about it, is there are gaps in the US market where there is not a lot of successful data sharing occurring. There may be a lack of a local data sharing network or low interoperable data sharing with the ambulatory EHR providers. So we are actually going to procure and stand up a national level gateway service, kind of like what you are doing, to fill those gaps. So I think there's a lot we can learn from each other and hopefully share to make it easier. So the lessons learned, I would say, more substantively fell into, I would say, 3 areas. One was legal, technical, and business and policy. So, and really even precursor to that is just lesson learned from how this whole thing started. So by having, I can say with all honesty, and I think my peers would agree, that it was absolutely imperative that the federal government stood behind the cooperative, that they funded it. They funded early real-world production instantiations, not pilots. No, 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 no. Pilot was a dirty word. You did not say pilot. Pilot was no, no, no. But it had to result in real data sharing. There's no test data, fake data. No, it had to be real stuff. So that was really important. They had a voice at the table. They provided guidance, but did not dictate. So that was really important. And then it was also important for there to be factors to drive that private sector adoption. And that's the early value case. Guess what it was from? It was not from my care provider exchanging data with a specialist. It was the federal agencies and the federal programs that had the value that they could bring to bear. So the Social Security Administration will pay for digital records. So that could actually offset the implementation of the entire gateway, that they could use that same technology to then access and share information with VA, and access and share information with DoD, and access and share information with the private sector. So the early nascent stages were the federal partners were really absolutely essential, foundational to this. It was also driven, the Veterans Health Administration was another huge driver. Veterans have some of the most complex care, and they really need active care coordination. And they've been through trauma and displacement and all these things, and they receive the lion's share of their care in the private sector, as do active duty military and their families. And so and also they refer care to the private sector. So that was another big one. And it was really through their leadership that they would go out and do outreach and to build that up. And then I think going forward to get private-to-private exchanges is primarily around value-based care models and population health management, and I think that's huge. But what makes this work is that the detailed workflow, implementation level details, implementation level policies really were driven by the actual implementers. So you could be on the outside and have an opinion, which is fine, but it was what worked in the real world, and that was always the litmus test for what held true. And it was also being able to incrementally change over time. So how we test today is completely different from how we tested in 2009. In 2009, we did weeks and weeks and weeks of intensive integration testing. Now it's automated, self-service, and we waive testing for qualified solutions sometimes. So that's the maturation. You have to be able to change and adapt over time. And then also other use cases beyond federal use cases is going to be pivotal for value. I would say the legal agreement was the legal benefit and lesson learned. And in here, I'll say that what it did was it eliminated one-to-one contract negotiations. I don't know if that's a big deal for you all or not, but for in the US, it was a huge deal. The first year alone, it saved $65 million. Now, the attorneys weren't very happy, but they would have liked that work. But what it did was you have one agreement, everybody had to abide by it. There's not one character or word is different. If you changed it, it had to change for everybody, right? So that was great. So there was also benefit in having those uniform policies and governance, and then since there was not a federal mandate, and there was not a real desire to have the government regulate health data sharing, that using that contract and the governance process was important. I think the other thing that we knew was important but truly value now is the value of having this activity facilitated transparently. All the specifications, all the legal agreement, key decisions that don't pertain to a particular participant, the level of participants themselves are all public. And the idea was to be inclusive and to share lessons learned and to take learnings back to SDOs and having visibility into what's going on. And then also having that baseline of what's, again, enduring while enabling innovation through new use cases and services is important. So I think that there's a lot of value to that. There are a number of technical lessons learned, and this is where there were some real pain points, and there still are pain points with this. Because we were trying to retrospectively go to the vendor community and ask them to change their technology solutions to adopt standards which were not in meaningful use or possibly designed pre-meaningful use, it's really challenging, both to the vendors and their R&D budgets, and the fact that they're largely driven by meeting regulatory requirements for electronic health records and HIUs, for instance, but also getting those standards and implementation guides tested sufficiently that there was an assurance it would actually work. So we would highly recommend, and since you all have the ability to do this right from the get-go, to have really, really tightly constrained specifications that are testable, and then also focus on the more detailed implementation level. It's not just specifications, but the data sharing policies. So we've spent a lot of time, I'm trying to think of one of the operational issues we talked about, sort of when do you require retesting, can you use an eHealth exchange certificate for other purposes? You get into a lot of the nuances of that. And then also consider consent and content and workflow issues. Once you start having activities working in practice, having a policy and technical work group, which I would highly, highly, highly recommend. That group was more active than the implementation guide work group and more active than the policy work group because they brought real-world issues that had a cross-section of policy and technology together, because they had to make decisions, and the policy people didn't want to make a decision that didn't work technically and vice versa. So it was super fascinating in discussions, but also super important. We found it very important while the original scope of this activity, when it was facilitated by HHS, was really broad in scope. The network focused on really simple starter use case, and rather than trying to get it perfect, get something that was workable and have a way to increment and improve and iterate and mature over time. So doing something simple is hard enough, but really trying to steer clear of trying to over-engineer. We also realize, even today, that collaborating early is important, so to avoid further silos. So while there have been a lot of really interesting and innovative new initiatives in the US, it's silo after silo after silo. And so how do we break that down and really just say, hey, we're looking to do, maybe we'll do something about prescription drug monitoring, that we need to support, responding to the opioid crisis. Well, we know these players are involved, these players are involved. Well, I don't want to do something independently. It's how do we bring it all together? So that was really, really huge. We have a lot to do around patient matching, but we did a study with Intermountain Healthcare, and actually they did the analysis to identify the root causes of why patient matching doesn't work between two different organizations, and guess what? It had to do with the data. The data was bad, and they used different rules, and one party defaulted to zeros if they didn't have a value, and others didn't. And we showed by fixing the data and having common rules and expectations and data attributes for matching, the match rates improved to 75% and then up to 90% with existing technologies. And that's without having a unique patient identifier. And again, it went up to 99.9 if you had an SSN. So there you go. I think the value of the data, so we've built this substantial connectivity, and my worry is it's so underutilized. Are clinicians happy? Is it helping them? When I go to my doctor, and I say, hey, how's this working for you? She's like, oh my gosh, I've got to go through 80 records and discern what is meaningful and not. And that's a miss. So, but again, does that mean we failed? No, that means we have to figure out how do we take this discrete data and make it more usable, more constrained, more consistent. And it's a journey, right? It's gonna be incremental process, and there's not going to be any perfection, no, anyway. And then there's also some missing infrastructure in the US that we're working with other partners to support. One is a healthcare directory. I don't know, are you all familiar with the Argonaut project? This part of HL7 Fire. I don't know if you're all part of that, but they've worked on a specification, so we've developed an instance of the directory. Do we want to own the directory? No, we want to contribute the code and the implementation guide and have a way that directories can interoperate with each other. So that's just a little bit about the key lessons there. From a business and policy perspective, it's interesting because we did the business model for the eHealth exchange, and we needed 60 nodes to sustain the network. And at 180, it's amazing the return on investment. And rather than costs are increasing over time, the incremental cost per partner is lower. So we're actually lowering our fees. And it's exciting. We're actually waiving testing. So testing used to be 20 grand to onboard. Well, now sometimes it's zero. So that's so exciting to have that shared cooperative public utility model, which I think is inherent, in what you all do, but that was different. There is a goal to test once and exchange anywhere. We are making progress in that perspective. It's interesting, some people thought, well, testing could be a business. It is not a profit center. It barely covers its own costs. So I mention that because there's this whole, we could talk another time about certification, but that there is, for us at least, testing and certification is not a profit center at all. It's a cost of getting this stuff working. And then, of course, the business case. The policy still, we just revised the DRSA, where it's undergoing federal partner review now. And when we looked at it with fresh eyes, there weren't that many changes. What we realized needed to change were the set of purposes for which data could be transmitted. But it wasn't privacy and security or incident response, was none of those. We had to expand some concepts to contemplate different types of partners and basically having to use more shared services, but there's a lot of enduring there. And then there are some issues I think I mentioned before that were very, we thought were problematic but aren't. But another one that's really, and again, this may not be an issue for you all, the one that policy I think that we're really struggling with is, can a participant charge another partner for treatment-based exchange? So there are business practices where, say you have a regional network and they've built this really cool CDR and they create this longitudinal record and this rich data and it's really high quality, but they want to charge someone else to access their data because someone else's data isn't. So there's just, our work is not done, and there's some interesting issues still coming to light. So with that, I will pause. I'm happy to take questions, and again, thank you, Lynn and Michael. So. Yes.
Hi, Iris Kish, patient partner. Thank you for a very clear presentation on what appears to be a complex project. But I do have a question. The patient data that is flowing from one to another, how do you maintain patient confidentiality? Do patients sign a waiver? What happens? How do you keep their data from being accessed by anyone who is part of this?
So the data reside in the provider system. The local law typically dictates whether the patient is subject, they have to provide an opt-in. So the veterans have to opt in, and there are a couple states, Florida, I think New Mexico, Minnesota, New York, have to opt in. The rest are opt-out. So there is a mechanism there for patient choice. But remember that the provider organization is the steward of the data, and they make a decision for every request that comes in on whether they respond. So that transaction comes into their system, and it indicates the purpose for which it's being requested, which is treatment. It indicates the provider organization and physician affiliated with that. And then it's encrypted, right? So it's this bit of data comes across, and then when the provider system receives it, it's integrated into the electronic health record. So it's provider to provider. It would be the same concept of, instead of faxing the information between provider systems, it's provider to provider. Now, I thought you were going to ask, where's the patient in all this? And so this is one of those things where we actually developed, this whole network was designed to have the personalized health records be the patient's lens and view into this network. So we developed the use case, and then we actually had 2 organizations that were going to use it, and then they never came forward. I think it's a big miss for that, but I thought that was what you were going to ask. Yes.
Hi. Anyway, I was wondering, I believe there is another similar non-for-profit, the Commonwealth Health Alliance, and I wanted to understand what's the difference and how do you guys work together?
Yes, we do. Well, that's a great question. So there is, as I mentioned, there are a couple other data sharing networks. The eHealth Exchange is one. It's unique because of its genesis as part of the government. But we realized that a couple years into it, there's not going to be one single data sharing network. And actually, that's a sign of a really healthy market, because it doesn't matter how a provider or patient is provided access to information, whether it's through a regional network or a network like Commonwealth, or believe it or not, SureScripts is just like Commonwealth, in that they stood up a national level gateway service and record locator service. So how many people here are familiar with Commonwealth? So there are a handful of vendors that got together to form their own data sharing network, and they architected it around a common record locator service and centralized gateway service. And so those vendors architected and integrated with that centralized service. So they are one of multiple data sharing networks out there with the eHealth Exchange. We have another initiative called KEYNOTE, which is the common legal agreement and framework that connects networks. So eHealth Exchange is in the process of becoming a KEYNOTE network. Commonwealth is already testing and will be live in early 2018. And then there are about 8 other data sharing networks, some of which are vendor networks. That's the other lesson learned. I think I glossed over it is, in circa 2009, do you think vendors were trusted as stewards of data and intermediaries? No way. They are now, and particularly in the ambulatory side, that vendors themselves are sometimes networks. So that's a very different world. So I think Commonwealth really signaled a shift, that the vendors are going to really develop an architecture to provide connectivity to their customers. And from our perspective, nonprofit, that's great. Doesn't matter to us, just get them connected and we'll connect to each other through KEYNOTE. So there's not one perfect network. It's going to be different based on provider type, based on the technology solution, their own workflow, and in our view, it's good.
Maria, thank you for sharing your story. And also I'm really impressed about the elements of the lessons learned that you captured. Thank you. My question to you is that I can't take out in my head the mental picture that you painted about you camping out of DC more than you ever wanted. But I just wanted to ask if you can take us to the initial conversations around influencing policies around what you're doing. So I would really love to actually hear more of that. Thank you.
Sure. So the initial conversations. Well, the idea for the eHealth Exchange actually came from a federal advisory committee back in 1999 to develop a nationwide health information infrastructure. And so they actually had some, I would say, principles around it, and ONC themselves had principles around it. I would say before the eHealth Exchange was started, they had what they call prototype architectures. So they didn't get too much into the details of the policies. They were more into what's an appropriate network level architecture that the federal government can stand behind. The federal government would not stand behind a centralized network architecture for the reasons I mentioned, because that's what led to the breakup of AT&T back in the 70s and 80s. And so they had to point to this federated kind of thing. But the policies, what led to it, I would say, was more in I'll tell you, to replay it, it was so fascinating. There was a legal and policy work group that had representatives from legal counsel, as well as privacy officers and business partners. And there had to be a representative of each. And they would basically, the way the conversations evolved, it was facilitated by an attorney. And it had, again, federal legal counsel there. The office that actually oversees privacy compliance with HIPAA, they were there. And they basically said, what are the things that we have to have in place? They came up with the sort of have-to-haves. And then they would do the analysis and say, here are the options. And you couldn't just reject it. You had to propose what would work. So if you didn't like the fact that there was, deferring to local policy, you have to come up with a suggestion. So that was facilitated over about 6 months before it got to, yeah.
I think we're going to call it on time.
Thank you, Lynn. Thanks so much. Thanks, everybody.